Menopause is again a Greek word. Pos is the end and main is the month. So, end of the monthly cycles refers to a period after 1 year has elapsed since the last menstrual period. Menopause refers to the period after 1 year has elapsed since the last menstrual period. During this period, women undergo physical, psychological changes which are a result of these hormonal changes. So, they can have mood swings, anxiety, stress, forgetfulness and sexual dysfunction. All these can take place during menopause. You have 3 patterns. The premenopausal is 16 to 42% have problems during premenopause, 39 to 47% get symptomatic during perimenopause, 5 to 60% postmenopause. Here what happens, symptoms of sleep complaints include difficulty in falling asleep, frequent awakening or early morning awakening. These are the predominant complaints and these can start off premenopause itself. Hot flushes is another problem which affects the sleep. These hot flushes emerge when the estrogen levels are coming down and this marks the menopausal transition. This usually occurs in about 80% of the women and these symptoms are caused by the estrogen withdrawal. Estrogen also plays a part in the brain and neural systems can be altered in vulnerable women, leading to more sensitivity to the effects of estrogen fluctuations where sleep also can get affected. So, what are these hot flushes? They are defined as sudden sense of body heat or redness around the face and neck, often accompanying by sweating, tachycardia and last for 3 to 10 minutes. They can be severe, frequency and duration can vary. Last for about 1 to 2 years after menopause. They will say, suddenly come and say, feeling very hot. Nobody believes I have got a temperature, feeling very hot and then I have sweating and I have this palpitation and all. So, that is one of the hot flushes and that affects women quite often and can last for anywhere between 3 to 10 minutes. Severity, frequency and duration can vary among women. So, what is the hot flushes got to do with hormones? Emerge as the estrogen level declines. It's much more complex than just a estrogen withdrawal. There is evidence of involvement of central noradrenergic activity as well as serotonergic mechanisms. That is why these drugs are also the SNRIs are also helpful in treatment of sleep. Most recently, they have shown involvement of the kisspeptin, neurokinin B, dynorphin related neurons in the hot flushes. So, these are newer developments. So, let us see what the hormone changes, estrogen and the progesterone have to do with the sleep disorders. Estrogen affects the metabolism of norepinephrine, serotonin and acetylcholine neurotransmitters and all these can affect sleep. Estrogen decreases the sleep latency and the number of awakenings after sleep occurs and cyclic spontaneous arousals and increase the sleep time. So, when estrogen is less, all these get affected and it also regulates the body temperature. During the night, estrogen plays a role in keeping the central body temperature low. This energy conservation takes place. Has a direct effect on the mood by affecting the noradrenergic activity and serotonergic response and serotonin response and uptake in the brain. So, estrogen has a role in the brain also. In contrast to that, progesterone is a sedative and anxiolytic features. It stimulates the production of NREM sleep associated with the GABA receptors by stimulating benzodiazepine receptors. So, this produces sedative and anxiolytic properties. Sedation is mainly because production of NREM stage associated GABA receptors and benzodiazepine receptors also acts as a respiratory stimulant and has been used in the treatment of mild obstructive sleep apnea. In this study, which is SWAN study, which is a very famous study where it studied thousands of women, they found that decreasing estriol and increasing follicle stimulating hormone levels were associated with higher odds of awakenings during follow-ups. And there is a greater change of FSH was associated with a poorer sleep quality. But so far, we are not getting the FSH drugs as such to treat the sleep. So, having said all that, what are the etiological causes which affect women in menopause which produce sleep problems? It is just menopause itself, aging, these vasomotor symptoms associated with it. There is depression, anxiety, pain here, there, osteoarthritis, other conditions like endocrine disease, medication, psychological factors, stress. They have completed their family life, they feel emptiness syndrome when the children are out of the house and you do not find yourself doing anything meaningfully. So, our goals of treatment will be the resolution of insomnia. If there is initiation problem, then you give something to shorten the sleep latency. If maintenance problem is there, then you give something to improve the total sleep time and make sure that sleep architecture is preserved and improve the quality of life of these patients. So, is there a role for hormone replacement therapy? Can it help? The main part of the replacement is the estrogen, which is used to treat the symptoms caused by the deficiency of estrogen, more of the vasomotor symptoms, and so they help by reducing the sleep disturbance. If you add progesterone, may also have benefit and has been shown to be associated with increased NREM stage 3 sleep, as already mentioned. Estrogen therapy in addition has an antidepressant effect. Menopausal symptoms because of early estrogen or estrogen progesterone therapy will be of benefit. Treating the vasomotor symptoms by estrogen improves the sleep quality, and estrogen also has a role in osteoporosis, mood disorders and depression.